Well, dizziness can be a million different things, and a lot of times when patients come in to see me in particular, they're somewhat confused about it and they have a hard time putting it exactly into words. I usually have them say it in their own words and then try to tease it out from there. But the way I usually explain it to them is going back to what balance is. And I explain balance as a tripod made up of the vestibular system as one leg, vision as one leg, and proprioception, or the sense of where we are in space in our legs. And vertigo, so to speak, can occur whenever they have any weakness in any of those legs. As far as dizziness versus vertigo goes, I try to tease that out with asking them a little bit more about what their symptoms are. And a lot of times they'll be able to describe it to me in terms of lightheadedness, near syncope, or a true spinning sensation or a falling sensation, usually accompanied with nausea or vomiting. And from there I can a lot of times tease it out even further by asking them questions about any precipitating events, how long they last, any positional preponderance, and that all helps me as far as seeing if there is an inner ear etiology. And we usually go a little bit further in teasing out any inner ear etiology by ordering some tests, specifically an audiogram as well as an ENG. A lot of times patients, particularly older patients who have had subacute strokes or patients who have diabetes, a lot of times their care is a little more involved in teasing out the diagnosis, and a lot of times we end up evaluating them for vertebral basilar insufficiency, and if an ENG comes back as negative, usually go on to an MRI just for a definitive test to make sure that there's nothing going on at the level of the vestibular system. Depending on what the results of our vestibular tests are in the office as well as the ENG, we can go ahead and sometimes treat patients right there and then in the office. Other types of vertigo that we do see include Meniere's and lymphatic eye drops and vestibular variant migraine headache. A lot of times we can treat patients with some vestibular therapy, and also if they have migraine headaches, forward them on to neurology. With the Epley Maneuver or the particle positioning maneuver, our goal is to reposition loose crystals in the inner ear from the posterior semicircular canal into the vestibule, allowing the patients to no longer be symptomatic. We have to have them keep their head straight for 2 days or 48 hours and not lay down so that these crystals can solidify in their new place. And like I said, 80% of the time this does work and allows them to be symptom-free.